Good evening, doctors. I hope I am audible and visible to everyone. So, you all are most welcome to our tutorial. And today's the topic is insulin release. It's very important integrated topic, and that is insulin release from beta cell and incretin phenomena. So, how insulin is released? Because this diagram will help you in integrating with your pharmacology as well as your medicine. A lot of drugs are based on this particular diagram. Okay, so how whenever we take food, it is converted to glucose, and that causes release of insulin, and how it act, and what are the drugs that are acting on that. So let me draw a simple diagram of beta cell. Beta cell of pancreas. There's a cell in the pancreas, endocrine pancreas, that is beta cell. Who can tell me, is doctor, which glut is present on the beta cell? Which glut? This is glut. This is the beta cell of pancreas. So which glut is present on the beta cell? Yes. Is it glut 1, 2, 3, or 4? It is glut 2. Glut 2 is present in the liver, intestine, kidney, and pancreas. So whatever food we are taking that is converted into glucose, that will enter inside the beta cell, and that will be converted into glucose 6 phosphate. We all know this fact, isn't it? Now, question number 2, which channel is present on the beta cell? What is the name of the channel which is present on the beta cell? That is ATP sensitive. This is ATP sensitive potassium channel. Listen very carefully. This is very important point. So this is the area for a lot of the drugs. So whatever food you are taking, that will enter inside the beta cell to get converted into glucose 6 phosphate, enter inside the glycolysis to form into ATP. Isn't it? Yes or no? Now, normally potassium keep on triggering outside. Potassium is more inside the cell or outside the cell? Inside the cell. So potassium will keep on triggering outside. But when we take the food, ATP is formed, and this ATP sends to potassium channel that will close. Yes or no? And if that will close, don't you think potassium will increase? That will cause depolarization, and that will open voltage gated calcium channel. Yes or no? Voltage gated calcium channel opens only when there is fluctuation in the voltage. When there is fluctuation in the voltage, calcium start being inside, and we know wherever there is exocytosis, you always need calcium. Yes or no? And inside the beta cell, you have insulin. What are this structure called as? This is simply your insulin. This is the structure of your insulin. So when we take food, this food is converted into glucose. Glucose enter inside the beta cell of pancreas to form ATP. This will cause closure of ATP sends to potassium channel, and that will cause influx of the calcium. So no, and this calcium will cause release of the insulin. Release of the insulin. Very simple. But can anyone tell me, is there any other mechanism beside this channel? This channel everyone knows that beta cell have ATP sends to potassium channel. Can anyone tell me, is there any other method to release insulin? That is G protein coupled receptor. Anyone can tell me? It is G protein coupled receptor. You can message me in the chat box. It is actually incretin. It is for incretin hormone. This is called as G protein coupled receptor, G stimulatory receptor for incretin hormone. I will discuss that also. But before that, this insulin is released must be known. Now, this ATP sensitive channel has a receptor for sulfonylurea. This is called as sulfonylurea receptor, SUR. Because all the drugs, sulfonylurea drug like glimepiride, gliclazide, glibenclamide, all these are sulfonylurea drug. These all are acting on this sulfonylurea receptor, and that is called as ATP sensitive potassium channel, and that will cause closure of the potassium channel. That is why sulfonylurea act on this particular receptor. This is the mechanism how this is released. Now there is also one more drugs, glenites, repaglinide and all. So they also have glenide receptor. So glenites, repaglinides, these are excellent drugs. You know that, especially to control postprandial hyperglycemia, repaglinides and all. So these also act on the same receptor, but they are different from sulfonylurea receptor. So both are called as insulin secretagogue. So by understanding this physiology, you understand two mechanisms, two drugs. One is sulfonylurea, other is repaglinide. One more thing is that I have told you one more receptor is present called as incretin hormone receptor. So doctor, tell me, what is incretin hormone or what is incretin phenomena? Incretin phenomena or incretin effect. What is that? Okay, just tell me answer. If I give glucose orally or IV, in which condition? In which condition insulin releases more? Yes, namaste, no? Namaste, everyone. Good evening. Farma, good evening. Hello, my dog. After a long time, I am seeing you all. Namaskar, Raja Tumma. Yes, tell me. What is incretin effect, doctor? If you give glucose orally and IV, in which condition insulin will be more and why? Suppose I am giving some amount of glucose orally to one person and IV to other person. What do you think? Release of insulin will be more in which condition? Answer is oral. If we take oral glucose in comparison to IV, release of insulin is more. This is called as incretin effect because in your intestine there are two cells. One is called as K cell, other is called as L cell. One is called as K cell, other is called as L cell. K cell releases a hormone called as, anyone? Keep on interacting. K cell releases a hormone called as GIP. L cell releases a hormone called as GLP. What is GIP? Yes, AK Patel, you are absolutely correct. When someone is taking orally, release will be more. Very good. So, because when we take orally, food will get inside the intestine and this will stimulate K cell and L cell to release incretin hormone. Yes, sir. Hello, hey. Please make one video on G protein. Absolutely. I will take a full 1 hour lecture only on GPCR. See, I will keep on regularly taking online classes. Just subscribe to this channel. Okay. So GIP is what? What is GIP? Don't say it is gastric inhibitory peptide. Please don't say it is gastric inhibitory peptide. It does not inhibit the gastric motility. Initially, when that was discovered by some scientists, they poured this hormone and motility decreases. But they have taken in the pharmacological dose. In physiological dose, doctors, these are not inhibitory motility. In place, they are releasing insulin. So the new name for this hormone is, nowadays it is called as glucose dependent. Now it is called as glucose dependent insulinotropic peptide. GIP is not gastric inhibitory peptide. It was the older name. At that time, we were not knowing the function, actual function. Actual function is not to inhibit the gastric motility. Actual function is to release the insulin from the beta cell via GPCR. Okay, and the second is glucagon-like peptide. This is more potent. It is called as glucagon-like peptide hormone. Both are acting on this beta cell doctors, and they are G stimulatory, so that will increase cyclic AMP and that will release the insulin. So don't say that release of insulin is only by one mechanism. No, there are multiple mechanisms. And that is the place of understanding of the pharmacological all those drugs which are acting on the beta cell. So now I have discussed about the four drugs. One was sulfonylurea. We have discussed about sulfonylurea drugs. Then we have discussed about glenites drugs, glenide and all. Then we have discussed about incretin drugs. Incretin. Now doctors tell me, sulfonylurea drug is acting on ATP dependent potassium channel, so they are releasing insulin even when you are not taking the food. See, normally when we take the food and insulin is released, that is good. But even when you are not taking the food and they are releasing insulin, so of course the main side effect will be hypoglycemia. Hypoglycemia. Yes or no? So normally when we take food and it is released, it will be balanced out. But when we are not taking food, only we are taking the drug that can cause hypoglycemia. And you know, insulin has anabolic effect also. That can also increase the weight. That can also increase the weight. So weight gain can happen. Glenides are also secretagogues. And incretin drugs. The one drug which is used in the market and that is GLP-1 agonist. GLP-1 agonist drugs like, who can tell me the name? Some of the name of that GLP-1 agonist. For example, exenatide, liraglutide, dulaglutide. There are so many types. These are simply acting on your GLP-1 receptor, doctor. But the only problem is that they are subcutaneous injection. These are subcutaneous injection. But recently FDA has approved one GLP-1 agonist that is oral. Injection also are there, but oral also. Who can tell me the answer? Yes, doctor. Yes, Dr. Viklesh Anand. Do you know the drug? See, GLP-1 agonist is a wonderful drug because they causes weight loss. They are wonderful drug. They are acting on the receptor GLP-1 on the beta cell. These are G protein coupled receptor. Liraglutide. Yes, anyone knows semaglutide? Have you heard about semaglutide? Yes, injections are also available, but this is FDA approved drug which is oral. Because only problem was that of course this is costly drug, and the main problem was their subcutaneous injection. See, sulfonylurea is excellent drug because it is cheaper, but it causes increase in the weight. And diabetic person is already obese. Namaste Chirag. Namaste. How are you? Diabetic person is already obese. Normally you see that. So you want to prescribe those drugs. So focus should be on those drugs which can decrease your body weight also. So GLP-1 agonist causes satiety. We will discuss in some other lecture about the physiology of satiety. So they causes satiety. So they decreases the hunger and they also decreases the weight. But the problem in the Indians especially, they are apprehensive about the injections. So now they are available as a oral drug also, doctor. Okay. In the same note, I want to ask you, which is the other drug that can also decrease weight? Besides GLP-1 agonist, is Dr. Khan. Besides GLP-1 agonist, do you remember any other drug that decreases weight? Recently asked question. Recently about the see, if someone asks you about weight loss, oral hypoglycemic drug that can cause weight loss also. One we have discussed already, GLP-1 agonist, because they causes satiety. Can anyone tell me about some other? Dapagliflozin, very good. Dr. A.K. Patel, very good. You are telling me about SGLT2 blocker, very good, excellent. Recently asked question about canagliflozin, SGLT2 blockers. Dr. Khan, metformin is weight neutral. It decreases very less weight. It is given in PCOD also because they are best sensitizer. Along with the pioglitazone, it is best sensitizer. But if you talk about the weight loss, these two are causing drastic. Up to 5 kilogram of weight loss has been seen with semaglutide. Right, okay. So anyway, coming to the topic again. So till now, only by one diagram, we have discussed these three drugs. The fourth drug is also based on this diagram. See, this GLP, who will tell me this GLP is degraded by which enzyme? This GLP, good evening, Entrance Valla. This GLP is degraded by which enzyme, doctor? Tell me. Anyone? Answer is DPP4. These are excellent incretin hormone, but they are degraded by enzyme called as DPP4. They are releasing the insulin, isn't it? But they are degraded by DPP4. Don't you think, doctor, if we give DPP4 inhibitor, if we give DPP4 inhibitors, we can increase time of action of GLP-1? Yes or no? Yes. So DPP4 inhibitors can also be used as a drug, and the best thing is they are oral, they are cheaper. Like for example, all the gliptins like sitagliptin, linagliptin, okay, sexagliptin. Then what else? Telnigliptin is not FDA put, also used in Japan and India. Sita, lina, sexa, elo. Okay, which gliptin is kidney safe? Recent MCQ from NEET PG. Which gliptin is safely given even if EGFR is less? Even if EGFR is less, doctors tell me which can be used in that. Yes, Rishikesh, sitagliptin. Only gliptin which can be even given if EGFR is less. That is linagliptin. Remember, linagliptin is the only gliptin which can even given in the kidney condition. It is kidney safe. Very good, Dr. Patel. Absolutely correct. Your answer is. So, now by this simple physiology, we can understand there are two incretin drugs. Now we can understand very simply there are two incretin drugs. And doctor, tell me why these are not causing hypoglycemia, especially DPP4 inhibitor, because this is released only when you take the food, isn't it? Anyway, this is your GLP-1 agonist. This is your DPP4 inhibitor. These are acting on the beta cell of pancreas. So, which is the only absolute contraindication of those drug, doctor? By that understanding simple physiology, what can be the absolute contraindication for these incretin hormones? Anyone? Absolute contraindication, pancreatitis. Already you are irritating the pancreas, and someone is already having pancreatitis. It should not be given. The absolute contraindication for these incretin drug will be pancreatitis. The best side effect, not side effect, the best additional effect is weight loss. Only GLP-1 is causing weight loss. DPP4 is weight neutral. DPP4 inhibitors are weight neutral. They are not causing weight loss. Simply remember, doctor, there are two main drugs that causes weight loss. One is SGLT2 blocker, because we know in kidney physiology we understand that SGLT2 is the main co-transporter that reabsorb glucose. So if you block that pump, glucose will come in the urine. Yes or no? Yes. So you can decrease not only HbA1c but also body weight. Body weight can also be decreased. So this is about incretin drug, doctor. Now insulin is released. Now insulin is released. This insulin act on which receptor, doctor? What is the name of the receptor on which this insulin act? Yes, doctor. What is the name of the receptor? What is the name of the receptor on which insulin plus all the growth factor act? Anyone can tell me? Dr. Patel, SGLT2 blocker. I told not GLP2 blocker. SGLT2 blocker. You discuss about SGLT2 blocker. Okay, I will discuss about that after that. Just let me discuss about the function of insulin. Then we will discuss about SGLT2 blocker. Okay. So insulin act on receptor tyrosine kinase. It act on receptor tyrosine kinase. Remember, very simple, one more thing. Insulin plus all growth factor except TGF beta. Insulin plus all growth factor except TGF beta act on receptor tyrosine kinase. Very simple. Okay. Now they act on insulin receptor substrate and activate two pathway, doctors. One is MAP kinase, mitogen activated protein kinase. Other is PI3 kinase. So there are two types of function of insulin. One is mitotic, mitogen associated protein kinase. This causes mitosis, means cell growth and development. This function of insulin is to cause cell growth and development, and this is causing metabolic. Don't think insulin is only metabolic hormone. The growth of fetus is mainly because of the growth factor and the insulin, not because of the growth hormone. So growth is also because of the insulin, so it is having mitotic role also. There are two pathways of this receptor tyrosine kinase. One is MAP kinase, other is phosphoinositol triphosphate kinase. It has metabolic function, and this is for cell growth and development, doctors. Okay. Now tell me one thing. What is the metabolic function? It act on which glut? Which glut is insulin dependent? Yes, Dr. Prem, Dr. Patel, Dr. Khan. Yes. Which glut is depending on the insulin? This is glut 4. See, suppose this is your muscle. These are your muscle, and this is your blood circulation. Please tell me, doctor, whatever amount of glucose is coming in the blood circulation, can this enter inside the muscle or not? Yes or no? Tell me. No. No, absolutely no. Why? Because glut 4 is in the center. Where is the glut 4? It is in the center. This is not in the periphery. Glut 4 is in the center. So when insulin comes, see, when insulin comes, this will act here and cause peripheral translocation of glut 4. So what is the role of insulin here? Role of insulin here is, doctors, to cause peripheral translocation of glut 4 from center to the periphery, so that, doctor, see, now glucose can easily enter inside the muscle. See, normally all glut, they are not dependent on insulin, but glut 4, if you see, they are inside the muscle and adipose tissue. So normally glucose, whatever food we are taking, it will be in the blood circulation. It cannot enter inside the muscle until there is presence of this insulin, doctor. So what is the metabolic function of this insulin, doctor? Metabolic function of this insulin is to cause peripheral translocation of glut 4 from the center to the periphery so that glucose can easily enter inside the muscle. That is why when we have insulin resistance or when there is type 2 diabetes or type 1 diabetes, muscles are hungry. They don't get enough. Yes, cardio life, metabolic, catabolic, anabolic terms are very confusing. See, insulin is the only hormone that is hypoglycemic. Remember, rest all, there's a mnemonic called as CHAMP-G. All can produce hyperglycemia. One is Cushing disease, hyperthyroidism, acromegaly, pheochromocytoma, and glucagonema. Because all these hormone causes hyperglycemia. Insulin is the only hormone, doctor, that balances this hyperglycemia. Remember that point. Okay. So how it balances? It causes influx of the glucose inside the muscle. So it is anabolic. It is providing glucose to the muscle. Otherwise, in diabetes, random blood glucose is so high. So why he is feeling so weak? Although glucose is there, but your muscles are thirsty. They are not going inside the muscles. So cellular utilization of the glucose become poor in condition of insulin resistance or diabetes mellitus. Okay, anyway, so this is the metabolic function of insulin. Now I have talked about the receptor. Now, what are the two drugs which are insulin sensitizer, doctor? What are the two drugs that are insulin sensitizer that act on the receptor level? That should be given always in case of type 2 diabetes, because type 2 diabetes, the main center is insulin resistance, not in type 1. Good evening, Dr. Anjali. Yes, tell me. What is the main? There are only two drugs that are not secretagogue, but they are working at the level of receptor. That should always be given if there is insulin resistance, doctor. One is commonly known to everyone, metformin. Very good, Dr. Rishikesh Anand. Excellent. The best drug is metformin. Very good, Dr. Patel. Pioglitazone, PPAR, gamma, not alpha. Gamma is for fibrates. They have work on triglycerides and all. PPAR gamma agonist. And that is, Rosie is banned, so only left is pioglitazone. They are excellent insulin sensitizer. So when insulin is released, but receptor is not working properly, there is insulin resistance. What is insulin resistance, doctor? When normal amount of insulin is doing subnormal action. When normal amount of insulin doing subnormal action. So problem is not with the release of insulin. Even there is hyperinsulinemia, but receptor is not working properly. So in those conditions, metformin and PPAR gamma agonist should be given. And the best, one of the best is pioglitazone. The only side effect, it can cause edema, ankle edema and all those things. It can cause weight gain also. And someone asks you, this is associated with which cancer? Although it does not cause cancer, but there is one study that showed association with their drug, but not is proven that it does not cause that. But sometimes they ask in the examination, which cancer this is associated with, doctor? It is urinary bladder cancer. Urinary bladder. Don't say it causes. No, it does not cause. Simply it is associated. You can say if someone has history, you should avoid that drug. So the problem here is that, doctor, it causes edema and weight gain. Otherwise, believe me, it is one of the best drugs because they are acting on which physiology? Receptor physiology. Especially in Indians, we are not having the problem. We are having central obesity, and central obesity is the root cause. See, if you are 100 kilogram and your whole body is in sync, it is okay. But you are 50 kilogram, but you have belly fat. The belly fat is the visceral fat that causes serine, threonine, phosphorylation of IRS1. That is affecting the receptor. Okay, am I clear? So, in all those conditions, always we should give metformin, we should give PPR gamma agonist. One point I want to just to integrate here with the gynae, that this is the drug of polycystic ovarian disease. This is the drug of PCOD, polycystic ovarian disease. So what can be the cause? This drug is the drug of choice for PCOD. Actually, PCOD is a nothing. It is not a gynecological disease. I should not say gynae. It is actually insulin resistance in the females. It is simply insulin resistance in the females. It is simply insulin resistance in the female. How? See, this is the ovary. This is suppose the fallopian tube, and this is the blood supply. You know, every 14 days, one worm have to jump, and fallopian tube catches that worm every 14 days. Yes or no? So that also need glucose. That also need glucose. Yes or no? But suppose some girl is obese. It is visceral obesity, and some girl is having insulin resistance. In that condition, this entry will be not perfect. So these ovums will not get enough energy to jump. So all ovum will be arranged inside the ovary. All ovum. So you get in the USG, if you do USG, you get necklace appearance. Yes or no? Why you get necklace appearance? Same physiology. And ovulatory cycles are going on, doctors. And if n ovulatory cycles are going on, what will happen? Ovary will be shiny or rough. Which ovary is good, doctor? Rough or shiny? Rough ovaries are good. Rough ovary means ovulation is happening. Ovulation is happening. Shiny ovary means cycles are going anovulatory. So if you give OCP, this will create a pseudo cycle that is not good. Even that can cause weight gain. It should never be given. Oral contraceptive pills, which is usually prescribed in PCOD, should not be never be given. Metformin should only be given. Because problem is not with the some ovary or all. Problem is insulin resistance. It is specific to the female. This insulin resistance, doctor, is specific to the females, doctor. Okay, so I'm just integrating, because now you know in the next pattern examination, question will be not like physiology question, what is the RMP, FANA question. They will give you case based question, and at the end they will ask you what is the mechanism of metformin in PCOD. Then you have to say it is a type of insulin resistance, doctor. That is why metformin is one of the best insulin sensitizer. Why don't you give pioglitazone? It can cause weight gain again. Problem is weight gain. So pioglitazones are not given in PCOD case because those females are already obese. So you should always give metformin. See, with simple diagram, you have integrated so much thing. Yes or no? Let me go back to the diagram and just summarize. See, this is your beautiful beta cell. So only when glucose enter inside beta cell, it is converted into ATP, and that is causing the closure of ATP sensitive potassium channel, causes depolarization, opening of voltage gated calcium channel, and this calcium causes exocytosis of the insulin, number one. Number two, you also have G stimulatory receptor, doctor. For which hormone? For incretin hormone, there are two. One is GIP from K cell, other is GLP from L cell. So GIP and GLP both are incretin hormone acting on the beta cell G protein couple receptor, and because they are G stimulatory, they will increase cyclic AMP. They will cause phosphorylation of protein kinase A that causes release of this insulin. This is the target for GLP-1 agonist. This is the target for DPP-4 inhibitor drug. So this is the target for sulfonylurea. This is the target for glenites. This is the target for GLP-1 and DPP-4. Now, we know hypoglycemia is by glimepiride and the most severe hypoglycemia is by glibenclamide. One question I want to ask you. Normally, no drug should be given in pregnancy. But if you have to give one drug, which is the only drug that can be given? Anyone can answer my question? Yes, Rishi Modia, Khan, Lim, Patel. You all are answering very nice. It's beautiful that almost everyone is answering wonderfully. Yes, doctor, tell me. See, normally insulin is the best to be given if someone is pregnant. You should never give any drug. But if you have to give, anyone can tell me? No one? See, it is having serious hypoglycemic complication also. But it can become glibenclamide. Actually, no drug should be given, but this can be given if they ask you like that. Otherwise, insulin is the only treatment. Someday we will also discuss about the physiology of all the drugs, long-acting insulin, short-acting insulin, ultra-short-acting insulin, all that will be discussed. So this is about physiology of release of insulin and incretin phenomena or incretin effect. So log in for success, and if you want, all my videos are now available on DocTutorials app. All my clinical integrated videos are available on DocTutorials app. Please download that. Okay. They are having wonderful question bank, integrated question bank, and all the clinical video, especially of physiology. I tried to integrate everything from physiology to thanks to pharma with medicine because you know about this. So if you want, I can also take some of the integrated sessions and you can suggest me topics. What topics, for example, we can integrate with the pediatrics like Bartter syndrome, Gilman syndrome, and all those things can be integrated. So please subscribe to Dr. Trail and also to this channel. We keep on taking live session as well. Thanks a lot. If you have any doubt, you can ask me. Cardio Life, all my videos will be available within a span of 5 to 10 days maximum. Within a span of 5 to 10 days, all videos, complete videos of all the system, especially we are discussing very much about the endocrine, especially thyroid, diabetes, and then neurophysiology, respiratory physiology. So from basic, not only clinical, from basic physiology to integrated with the pharma and medicine. Starting from very basic general physiology, then cardiophysiology, integrating with all these subjects. Okay. So any doubt you can ask me. Should I stop now? And also you can suggest me topics in the comment section. What topics you want me to take live. Okay, then thank you. Thanks a lot everyone. For any query you can just type here so we can solve that query also regarding app, regarding videos, regarding question bank. Because as we shifted from PG to next, you know all things are adrenal gland, cardio life, of course. The next class will be on congenital adrenal hyperplasia. I will also share the mnemonics, how to remember 21 hydroxylase deficiency, 17 and 11 and all those. Yes, acid base, wonderful. Two topics are now 100% I will take. Acid base, metabolic acidosis with high anion gap, normal anion gap, then the compensation with the respiratory, urinary anion gap, all this will be discussed. For that I need at least 1 hour. That will be taken live. Any other suggestion or any other doubt? Really thanks a lot to all the doctors to join this class. More correlation with pathology. You can suggest me any topic for correlation with the pathology. I will. One topic I can take on the physiology of the insulin in more detail. How it causes all the biochemical reaction and all those things. This was only a demo class so that I could integrate everything. Yes, Dr. Sonali, ECG reading. Okay. Thanks a lot, Dr. Prem, Dr. Cardio Life. Adrenal gland I will take because adrenal gland is correlated with the biochemistry also. So I will discuss the whole cycle and I will try to make you remember also. Mnemonics, mnemonics are needed for that. थोड़ा सा इसमें mnemonics चाहिए होगा. I will do that. I will give you only three mnemonic. With that three mnemonic, you can remember all the questions from 21, 11 and 17. ECG reading. Sure. I will discuss the physiology of that and medicine faculty from DocTutorials will discuss in more detail. I will start the very basic of ECG and then he can continue. Yes, Dr. Rex, cardiophysiology in depth. Cardiophysiology in depth. Of course, I'll do it. But it will be better if you suggest me some topic like biggest diagram or pressure column loop curve or electrical activity of the heart. ना अगर टॉपिक बताओगे that will be more better. Yes, G protein. Yes, G protein. Not only G protein, I will discuss G protein. G protein will take at least 1 hour because it will integrate with the microbiology. How cholera toxin, how this pertussis toxin, how they are acting on G protein. Then there are mutation of G protein like pseudo hyperparathyroidism. Then there is McCune-Albright syndrome. Then there is Albright Osteodystrophy syndrome. So all these topics are linked with only GPCR. So Doctor, hello, hey, of course I will take in very much. Linear graphs. And those who are in doctoral, they can just see the video. They are going to come in not more than 1 week. Almost work is done. All videos will be available. Okay, I should say bye now. You can also suggest in my Telegram group all the topics. You can just suggest there. I will take the topics one by one. All graphs and calculation. See, graphs and calculation are mainly in the respiratory physiology. There are eight calculations. There are eight formula and six graphs, mainly in respiratory. That can be integrated with anesthesia. Electrical activity of heart with ECG and diaphragm. Sure, absolutely I will. So now I am available my full time in tutorial. Recorded session will be there. Live I will keep on taking. Any doubt in the video, if after seeing that you can just suggest me. I can take more of the live so that recorded and live can be integrated more and more. Okay, so bye. Thank you. Good night. Take care.